My name is David Polly, and along with Zogo Gawala and Mike Steinbetz, we will be the debate moderators for the Cahill debates. The good news for me is I am not the smartest person in the room, so according to Confucius, I must be in the right room. I knew David Cahill, and everyone who knew him, I think, would say that he was an iconoclast who promoted vigorous discussion. Our first debate is to go big or to go small. And our debaters are Bob Eastlack and Greg Mundis, who are partners in San Diego and have never, ever before disagreed on surgical planning. So let me hand it over to Bob, and you're up first.
All right, so my task was to talk about limited fusion and how it works great. There's less morbidity, happy patients, and sufficient durability. Disclosures. So I'm going to show a case that's actually quite similar to what Dave just showed, an 82-year-old woman, chronic low back pain, some progressively worsening back and right leg pain, hip pain, and deteriorated function. Some osteopenia, and you can see the imaging there. So I'll let you kind of keep that in the back of your mind as we go through this. But first, let's talk about Greg. So Greg and I have a long, I won't say complicated, but deep relationship on many levels. He was a fellow of mine early in my career. He's been a long and cherished friend, partner in our practice, and even a patient. So needless to say, I'm a little torn going below the belt on Greg. And I'll add, Greg has an amazing compassion. As you all probably know, he's been involved in global spine outreach and has an enormous heart and passion for what he does. You also know, if you know Greg, that he's incredibly passionate about deformity, even evangelical to a degree. And the fellows that we've trained who are out there in the audience and beyond know that they are disciples of his with respect to deformity mindset. And they also know Greg can achieve some amazing deformity corrections with these surgeries. The other good thing about being a partner is I get lots of dirt from the fellows. But really, what could go wrong with these big surgeries? Obviously, the dreaded PJK. And as you know, Greg's a stickler for alignment. He can get that L1PA looking just fine, and that patient's doing great. The risk most people fall into is, hey, let's just take care of everything and go big. Then you don't have to worry about more surgery. Oh, that didn't work out so well, did it? So let's do a reality check. Big surgeries usually mean big problems. If you look at the elderly population, 30 to 70% complication rate. And these are retrospective reviews, so they missed a fair number. If you look at the complications in the elderly there, you get major complication rates that are 9 times that of smaller surgeries. So huge risk with these big surgeries. Major complications abound. And even in our own group, the ISSG, when we looked at what you'd think would be fairly accomplished spine surgeons doing deformity work, 70% of these patients suffered complications by 2 years, and nearly 30% required reoperations. So huge risk within a 2-year time period, not even withstanding the longer-term outcome. Well, what about going a little smaller? Can we mitigate the risks? Selective or limited fusions. One of the forays into this was Neil Anand's work, looking at double major curves and just selectively fusing the lumbar curve, and he found modest reciprocation of the thoracic spine and only 5% required extension. So there's perhaps something there. Another study looking at more limited fusions in the lumbar spine, and what they found was that there was acceptable improvements in outcomes with ODI and NRS in a durable fashion using a limited fusion mentality and approach. And then Dean Chow and his team at UCSF looked at the fractional curve concept. Many of these deformity patients will sort of wane with respect to the onset of radiculopathy at a fractional curve level. And they looked at the ability to make these patients better simply by treating the fractional curves and compared those with a group of patients that went for the big one. And what they found was a striking difference in complication rate, 20 versus 60%. And further benefit, lower EBL, less hospital stay, and most of the patients with fractional curve treatment were discharged home. Importantly, those patients really only had extension or adjacent surgery rates of about 26%, which is not strikingly different from our deformity patient numbers. The outcomes of short fusion versus long fusion for adult degenerative scoliosis in a systematic review came to the same conclusion that the ODI was comparable across both cohorts. So if the shorter fusion lengths were clinically indicated, they should be used instead of longer fusions to reduce perioperative time, costs, and other complications. So back to our case, older, more fragile woman, did further workup to define the problem, and she went on to get a minimally invasive limited fusion and is now a year and a half out doing wonderfully with respect to outcome and function. So these choices can be done in fractional curves, as you see here, with more frail patients, like you see this pulmonary hypertension patient with a high BMI, deformity, and being able to perform limited fusion and achieve some clinically relevant success is a wonderful advent. So selective fusion should be considered with focal symptomatic pathology, compensated deformities, elderly, bone health deficiency patients, symptomatic fractional curves, and multiple comorbidities. And we address these ideally with MIS techniques if it's feasible to achieve your technical goals, normalizing and optimizing segmental alignment restoration, and avoiding worsening of global coronal or sagittal alignment. So let's keep Greg on the trail instead of heading off into the hinterlands off his bike.